Hey guys, it's Olivia. Welcome back to your endocrinology chapter. We discussed some of the anatomy and the function of the adrenal glands in our last videos. Now let's discuss what happens when these adrenal glands are not functioning in a pathology called adrenal insufficiency. So before we dive into adrenal insufficiency, let's first review our pathway. So first we're going to have our hypothalamus. Our hypothalamus in our brain is going to be releasing CRH that is going to travel to the anterior pituitary. Our anterior pituitary secretes adrenocorticotropic hormone that will travel to our adrenal glands, stimulating them to release, in this case, cortisol. And it's important to remember that there are three glands involved in this pathway: the hypothalamus, the anterior pituitary, and the adrenal cortex, because a defect anywhere along this pathway can lead to adrenal insufficiency. And which gland is deficient is what is going to determine whether we are in primary, secondary, or tertiary adrenal insufficiency, respectively. So primary, it's something wrong with the adrenal cortex. Secondary, it's probably something wrong with the pituitary. Tertiary is something wrong with the hypothalamus, etc., etc. But what happens when we have adrenal insufficiency? When we have adrenal insufficiency, we are going to see a decrease in all the different hormones that our adrenal cortex is responsible for making. And those are going to be our glucocorticoids, our mineralocorticoids, and our androgen. First, we'll talk about our glucocorticoids. If you remember, our glucocorticoids are made by the zona fasciculata inside of our adrenal cortex. And an important role of one of our most famous glucocorticoids, cortisol, in normal physiology is going to be maintaining blood pressure. So cortisol is incredibly important for the regulation of the RAS pathway. Remember, renin-angiotensin-aldosterone system. This pathway is responsible for regulating sodium levels, regulating vasoconstriction, and all of these different components that are responsible for maintaining blood pressure in the body. So cortisol is important for blood pressure and RAS activity. Cortisol is also going to increase glucose in the bloodstream, as well as have some anti-inflammatory properties. So these are all going to be the role of cortisol in normal physiology. But what happens when we don't have enough cortisol because our cortex is not making it? When we have decreased cortisol, this is going to lead to our pathology. And our pathology of decreased cortisol is going to be the opposite of our physiology. So we talked about how cortisol is responsible for maintaining blood pressure and RAS activity. Some pathology associated with decreased cortisol is going to be orthostatic hypotension. So this inability of your body to maintain adequate blood pressure when standing up. Additionally, we mentioned cortisol increasing glucose in the bloodstream. Similarly, when we don't have enough cortisol, this can lead to hypoglycemia, as well as other symptoms that I associate with energy in my mind, like weight loss, weakness, fatigue, just having decreased energy because cortisol is so important for increasing glucose in the bloodstream, as well as some other metabolic pathways. Additionally, when you have decreased cortisol, you might see muscle aches or GI symptoms, and these can all be part of the pathology associated with decreased cortisol that we might see in adrenal insufficiency. The next group of hormones that our adrenal cortex is responsible for making and are deficient in adrenal insufficiency are mineralocorticoids. Our mineralocorticoids are secreted by our zona glomerulosa that is inside our adrenal cortex. And in normal physiology, our most important mineralocorticoid, aldosterone, is going to be responsible for increasing sodium reabsorption and potassium excretion in our distal tubule and collecting duct. So if you remember, there's this sodium-potassium exchanger in the kidneys, and the activity of the sodium-potassium pump is going to be upregulated by aldosterone. So when we have aldosterone released in normal physiology as part of the RAS system, it is going to increase our sodium reabsorption and increase our potassium excretion, meaning that we have more sodium inside the body. More sodium inside the body can pull in more water and help us maintain that higher blood pressure. So also important role for blood pressure here as well. Pathology occurs when we have decreased aldosterone. When we don't have enough aldosterone, first, we are going to get a buildup of potassium, so that makes sense, right? If we are not excreting as much potassium, then that potassium is going to be retained inside the body. Increase in potassium is actually quite relevant for differentiating type 4 renal tubular acidosis from other types of renal tubular acidosis. So type 4 renal tubular acidosis can also be seen as a result of decreased aldosterone. In type 4 renal tubular acidosis, we have a decreased urinary excretion of ammonia. This is going to lead to a non-anion gap metabolic acidosis. So it's important to remember here that this is a non-gap metabolic acidosis because it will help you differentiate this from other causes of a gap metabolic acidosis. And you'll often see this specific type of metabolic acidosis referred to on step 1 by a very long name, a hyperkalemic, hyperchloremic, non-anion gap metabolic acidosis. And that's basically everything we just said, right? So there's going to be increased potassium. We already talked about that. Additionally, we're going to have a hyperchloremic acidosis. So there will be increased chloride levels as well. Think about our cations and our anions balancing out. We're going to have increased chloride retained to balance out some of those other positive cations that we are going to be retaining. And then once again, this is a non-anion gap metabolic acidosis, as most of the renal tubular acidoses are. The final group of hormones produced by your adrenal cortex that can be deficient in adrenal insufficiency are our androgens. And our androgens are mostly deficient in primary adrenal insufficiency. They're produced by your zona reticularis. And in normal physiology, our androgens are responsible for things like regulating your energy level, regulating concentration, mood, in addition to their effects on the reproductive systems in both males and females, playing an important role in menses in the female and libido. And this is going to directly relate once again to what happens in pathology when we have too few androgens. If we have too few androgens, because they are responsible for energy, concentration, and mood, this is going to lead to a depressed mood and poor energy, in addition to decreased concentration. And then in females, you can see irregular menses, as well as erectile dysfunction in males because of the important role of androgens for libido. Finally, in addition to the hormones that the adrenal cortex is responsible for making, I want to point out that in primary adrenal insufficiency, when we get a buildup of ACTH, remember that's only going to be happening in primary adrenal insufficiency, because in primary adrenal insufficiency, our adrenal cortex is not working. So there is nothing to exert negative feedback on the pituitary or the hypothalamus, and thus we get increasing levels of ACTH as well as CRH. So in primary, everything behind the adrenal cortex in this pathway is going to build up because the adrenal glands are the blockage here. So we have increased ACTH in primary adrenal insufficiency, and there's an important clinical tie-in with this increase of ACTH. So ACTH is a protein that is encoded for by the POMC gene. So the POMC gene is transcribed, and one of the proteins it makes is ACTH. However, other proteins that are also encoded on the POMC gene and frequently transcribed with ACTH are beta melanocyte stimulating hormone, as well as alpha and gamma melanocyte stimulating hormone. And because all of these proteins are transcribed from the same gene as ACTH, when ACTH levels rise, such as in primary adrenal insufficiency, you can also see a rise in the melanocyte stimulating hormones. Melanocyte stimulating hormone, exactly like it sounds, stimulates your melanocytes to create more melanin, and this is going to lead to an effect of hyperpigmentation. And this hyperpigmentation is the reason why I have included this picture of JFK on your slide. The media love to remark on his classic tan that was attributed at the time to his love of sailing. But in actuality, JFK's tan probably resulted more from the fact that he had Addison's disease and thus had this constant hyperpigmentation, leading him to appear tanned or copper skinned in the middle of winter. So I've included him on your slide here as a memorable tie-in that I hope will help you remember the fact that hyperpigmentation and copper skin can also be associated with adrenal insufficiency if it is primary adrenal insufficiency and we also have this buildup of ACTH. I know that was a lot of information. Let's quickly recap what we talked about in this video. Adrenal insufficiency can result in a defect from anywhere along this pathway, but it results in a decrease in the hormones that the adrenal cortex releases. The symptoms that you should look for include fatigue, orthostatic hypotension, hypoglycemia, a type 4 renal tubular acidosis, and then mostly in primary adrenal insufficiency, irregular menses in the female, erectile dysfunction in the male, and hyperpigmentation of the skin. Think about JFK's tan. And then how would they ask you about this on a board style question? Well, something they might ask you is a 26-year-old man presents to his physician for 4 months of inability to achieve an erection, weight loss, and feeling like he can't get out of bed in the morning. Exam reveals a thin 26-year-old man with copper-toned skin. Labs reveal a fasting glucose of 52. What region of the adrenal cortex produces the hormone most likely responsible for this patient's hypoglycemia? So we have a picture of a young man who has erectile dysfunction, he has fatigue, he can't get out of bed in the morning, fasting glucose is quite low, so he's also exhibiting some hypoglycemia. All of these things that should be tipping you off that we could very well be talking about adrenal insufficiency. And the question asks us, what region of the adrenal cortex produces the hormone most likely responsible for this patient's hypoglycemia? Well, a hormone that is made made in the adrenal cortex and is responsible for regulating glucose in the bloodstream is going to be cortisol. So a deficiency in cortisol could certainly be responsible for this patient's hypoglycemia. The question then asks us, what zone of the cortex is cortisol made in? And that zone, because you watched this video, you know is going to be the zona fasciculata, and that would be your answer. Now I hope you enjoyed this video, and I'll see you next time.